Key phrases you can use to manage a 2-week-old baby girl with jaundice during your clinical exam. History taking. General questions. How has your baby been feeding since birth? Have you noticed if the baby has been more sleepy or less active than usual? Are you breastfeeding, formula feeding, or a combination of both? Jaundice specific questions. When did you first notice the yellow discoloration of her skin or eyes? Have you noticed if the jaundice has been spreading or becoming more intense? Does she seem to cry more often or appear irritable? Other symptoms. Have you noticed any change in her stool color? Is it pale or clay colored? What color is her urine? Is it darker than usual? Has she been gaining weight appropriately since birth? Maternal and perinatal history. Did you have any complication during pregnancy or delivery? Was your baby born full term or preterm? Did the hospital check for jaundice before discharge? Family history. Does anyone in the family have a history of jaundice or liver issues? Are there any blood disorders such as G6PD deficiency in the family? Examination. Transition to examination. I'd like to examine your baby now to check for signs of jaundice and her overall health. I will gently press on her skin to see how the yellow color changes and examine her eyes as well. During examination, I am checking her skin, eyes and the palms of her hands for jaundice. I'll palpate her abdomen to check her liver size. Let me assess her hydration status and look for any signs of poor feeding. Management and reassurance. Initial reassurance. It's common for babies to have some jaundice in the first few weeks of life, but I'd like to make sure it's not due to an underlying problem. Most cases of newborn jaundice are mild and resolve on their own, but we need to monitor it closely. Investigation. I would recommend a blood test to check her bilirubin levels and rule out any underlying causes. We might also test her for blood group compatibility and check her liver function. Management plan. If the bilirubin levels are high, she may need phototherapy, which is a safe and effective treatment. We will monitor her feeding closely because adequate feeding helps reduce jaundice. Red flags. If you notice she becomes very drowsy, stops feeding well, or develops pale stool or dark urine, seek medical attention immediately. Any worsening of her jaundice or unusual behavior should be brought to my attention. Follow-up. Let's schedule a follow-up in 2 to 3 days to reassess her jaundice and review her blood test results. If she doesn't improve or if her symptoms worsen, we may need to refer her to a pediatrician. Counseling. Breastfeeding jaundice. Sometimes jaundice can be related to breastfeeding, but this doesn't mean you should stop. Let's ensure she is feeding effectively and frequently. Preventive advice. Make sure she is feeding every 2 to 3 hours and keep track of her wet diapers and stools. Excluding differential diagnosis. When excluding differential diagnosis such as sepsis and viral illness contact in a 2-week-old baby with jaundice, it's essential to systematically address these possibilities through history, examination, and appropriate investigations. Sepsis. Sepsis is a life-threatening condition that should always be ruled out in a neonate presenting with jaundice. In history, the general symptoms: Has your baby been more irritable, lethargic, or drowsy than usual? Has she had any fever or episodes of feeling unusual, cold to touch? Feeding. Has she had difficult feeding or feeding less than usual? Has there been any vomiting? Stool and urine output. Has the urine output decreased or her stool pattern changed? Have you noticed any foul-smelling discharge or unusual color in her stool or urine? Birth-related risk. Were there any complications during delivery such as prolonged rupture of membranes or maternal fever? Did she require antibiotic or special care at birth? Examination. Look for red flags. Hypothermia or fever. Poor tone or lethargy. Signs of dehydration. Sunken fontanella, poor skin turgor. Respiratory distress or tachypnea. Check for local infections. Umbilical infections, redness or discharge, skin pustules or rashes. Investigations. Full blood count to identify leukocytosis, leukopenia or thrombocytopenia. Blood cultures to confirm or rule out bacteremia. CRP or procalcitonin, markers of inflammation or infection. Urine culture to exclude urinary tract infection, a common cause of neonatal sepsis. Exclusion. If the baby is clinically stable, afebrile, feeding well, and has normal lab results, sepsis can likely be excluded. Contact history of viral illnesses. Viral infections, example cytomegalovirus, rubella, herpes, hepatitis, or other congenital infections can also cause jaundice. In history, maternal history. Did you have any infections or rashes during pregnancy? Did you receive screening test for infections like rubella, cytomegalovirus, or hepatitis? Exposure to infections. Has anyone in the household been unwell recently with fever, rash, or flu-like symptoms? Have you had visitors who were unwell? Other symptoms in the baby. Have you noticed any rashes, unusual spots, or vesicles on her skin? Has there been any excessive irritability or poor feeding? Examination. Look for signs of congenital infections. Hepatosplenomegaly, petechial rash or purpura, blueberry muffin rash in torch infections, microcephaly or abnormal head shape, cataracts or other eye abnormalities. Investigations. Torch screening to rule out congenital infections, toxoplasma, rubella, cytomegalovirus, herpes, syphilis, if indicated. Liver function test. Elevated liver enzymes or direct hyperbilirubinemia may point toward infectious causes. PCR test for cytomegalovirus, HSV, or other suspected viruses if indicated. Serology to assess maternal immunity to rubella, cytomegalovirus, or hepatitis if indicated. Exclusion. If there is no significant maternal or contact history and physical examination and specific investigations are normal, a viral cause can be ruled out. Conclusion. To conclude these differentials, a thorough history can help rule out risk factors or exposure. A focused examination ensures no red flags are missed. Tailored investigation confirms the absence of these conditions, enabling you to focus on primary cause of jaundice. Example, physiological jaundice, breastfeeding jaundice, or ABO incompatibility.